welcome Skip Gregory. He is the president of Health Facility Consulting. From 1986 until his retirement in June of 2010, Skip worked for the Agency for Healthcare Administration, first as a review architect and then as Bureau Chief of the Office of Plans and Construction. He's a registered architect, a certified fire safety inspector, and a member of the National Council of Architectural Registration Board. And he'll be followed by Linda and Ellen.
All right, thank you. Hey. Can you hear me all right? Can you hear me now? Okay. We're going to talk a little bit about the guidelines, and before we're going to do that, we're going to talk about a little bit about what happened before the guidelines. The Aztecs were ripping people's hearts out on pyramids, and the Egyptians were building their own pyramids, and then this guy was having his leg amputated. So that was before the guidelines. And after the guidelines, we have what we have today, which maybe in some cases isn't that different, but we're trying to make a difference. So I'm going to run through a quick history of the guidelines for you if you're not that familiar with that particular document. This is taken from the 2010 preface. Each edition of the guidelines, the preface part extends the history as it goes forward. So back in 1947, there were some standards under President Truman. That's over 60 years ago, I guess. And President Truman was trying to do something with medical care throughout the United States, and the Hill-Burton Act was created by Senator Hill from Ohio and Senator Burton from Alabama to give money to states to build and renovate hospitals. And of course, as you know, with the money from the federal government, it's never free. There's always strings attached. And so there were some strings attached in this case, which had to do with the design and construction of those facilities. That went on without any public input for a number of years until 1974, when the standards that were under the Hill-Burton Act were renamed and to include minimum standards. So there was then revised by the federal employees with some public input. That rocked along until 83, 84, when the guidelines were actually removed from regulation and renamed, and then that's when they became called the Guidelines for the Construction of Equipment, Hospitals, and Medical Facilities. Even though the regulations then had gone away and they were no longer to be enforced by the federal government, some state authorities having jurisdiction still used them because that was all anyone had. 1987 was the last time that that particular document was published, and after that it was terminated by the federal government in President Reagan's effort to cut down on any kind of regulation, but it was then picked up by the AIA and AAH for that support, and it was then that particular document was actually published. After that, for the next publication, it wasn't going to happen. Now, if you read the preface to the 2010 guidelines, you won't see the names of Armin McGunn, Joe Sprague, or Doug Erickson in there. It just says 3 people. But those were the 3 people that basically took what was going into the trash can and found a home for it and resurrected it and went to the effort of getting public document for this important work. And so that was actually the first time, I guess you would say, that the Guidelines Committee actually existed. Anyone in this room serve on the 1992-93 Guidelines Committee? No one? Okay. After that, the committee was expanded for the next edition, 96-97, to over 65 people, and that's when the name was changed to the Guidelines of Design, Construction, and Healthcare Facilities, and that committee was run by Joe Sprague. Do you know Armin McGunn? Do any of you know Armin? Okay, well, you know Armin gave a very impassioned speech during the debates of the 2006 edition of the Guidelines for Single Patient Rooms. And I will never forget him standing at the podium and swaying the votes, my vote in particular, towards single patient rooms. So I would just, as a side note, it is really a great guy. But Joe Sprague took over the committee chair for the next three editions, the 96, 97, 2001, and 2006. The 2006 is the one that was very interesting because that was the one that made the decision to require all new healthcare facilities, hospitals, and their med-surg rooms at least, to design only private rooms. And that was based on some evidence that was hotly debated for 3 years. I flip-flopped myself as one of the people that voting on those standards. I've been on 4 guidelines committees now, and I will tell you that it was, if you left the room at the wrong time, perhaps your position got changed, and so we all stayed, and it was quite exciting. At that time, the committee was expanded to 124, and by the way, back in 2001, they started adding more and more authorities having jurisdictions, such as myself, to the committee. Roger Gregory from Idaho was also on those early committees. And the reason, it was a good reason, to add the authorities having jurisdiction is that they felt that if they could get the authorities having jurisdiction onto the committee, they would adopt it, and the book would be used more throughout the United States, which it is now. Angela just said 42, I think, states adopted. Florida just adopted the 2010 edition itself. So that was one of the driving forces since the 2001 edition to expand the committee to include authorities having jurisdiction. Now the 2010 edition is unusual in that Part 6 now is incorporated ASHRAE 170, which is the standard for ventilation and heating controls in the healthcare facilities, and we also added all those sections that you know that we're talking about today, having to do with lighting and noise control, and the FAMA as a patient handling, which will be talked about a little later. So that's what it looks like when everybody's in the room. And how many people are on the guidelines committee here? I don't know, we got a bunch of them. Yeah, okay. So all you guys know, that was from the last meeting we held. So we're all sitting around, and then we sit around in small groups. Now the guidelines is made up of the board. No monetary compensation is given to the board. 100% of the income goes to guidelines research, which is run by Jim Mercier. Purpose of the guidelines: set minimum standards for program and space, and it's referenced now by JACO and a number of other important associations and agencies for hospitals. So, by the way, it's not a code requirement until it's adopted by states. This is the general structure. It's a steering committee, and I think David Uhays and Jim. Who else is on the steering committee here? Linda. Okay, so the steering committee has overall arching control of what goes on and the general point of where the guidelines are going. Then these are subdivided into these various committees here. As you can see, this is the large committee that meets 3 times during the 4-year cycle, and we all have what they call all hands meetings to do the work. But most of the work is done in the park groups, and then below the park groups there are focus groups, and most of the work is being done now. If you want to, by the way, if you want to get a revision into the guidelines and pet peeve of yours or something you feel like we didn't do very well, certainly you have to get it in by the end of this month. So if you want to do that, see me afterwards. So it's the guidelines are written. Part 4, which is the long-term care section of the guidelines, which is going to be split out this year, and they're going to be actually 2 separate books, Part 4 becoming residential facilities, and Part 1 being outpatient and hospital and other healthcare facilities. Part 4 is written primarily in a performance-based situation, which isn't HJs don't like performance-based. We like prescriptive standards. We like something that you can enforce. So we've been working really hard all these years since 2001 to get all the shells into the white text and all the shoulds into the appendix text. And so when you're looking at writing standards for the guidelines, just be aware that if you want something to be enforced, you have to use shall. And if you want it's like a good idea, just use should, and it'll go into the appendix material. And that's what this says here. Appendix material contains best practice information. And that's where all the shoulds go. Question, where are the guidelines going from here? I think this group is going to have to talk about this a little bit. Some of this was mentioned yesterday. Are these guidelines going to be a minimum standard or a best practice guide? And that's one of the questions that always comes up. Another question that comes up all the time during the debates is, are we dealing strictly with sticks and bricks of the building, or should we include operational issues as well? And that's certainly in this patient risk assessments, those are very, you really walking a line there. Is there really something called evidence-based design, or are we still making requirements based on a singular bad experience? And I don't know. That's still something that's being kicked around and debated. What's the cost benefits? And we have a whole committee now looking at cost benefit when somebody comes up with a great new idea, like having parking spaces for bicycles, you know, and those kinds of things. Should the guidelines focus only on patient and resident health and safety issues, or should staff be included? And I think that was mentioned yesterday about a situation. Where are we drawing the line on that? And if we're going to expand to staff, how does that play into OSHA and all the other kind of staffing requirements? And then, should the guidelines be an advocate for green technology? And we certainly have those revisions being pushed into the guidelines every year by advocates for that kind of thing. So those are lots of questions that are going to have to be answered in the next few years. But no matter what the future holds, I put this slide up here because I thought it was kind of a symbolic. You don't want the conversation being focused around here and ignoring the dummy in the corner of the room. So that's right. That's the history of the guidelines.
Thank you, Skip. Good afternoon. My name is Dickey. I'm from University of California, Irvine. And just a little bit of background, I'm a nurse by training. Went to the University of South Carolina. Where's my Clemson friend? There you are. Our rival in the front. And
you're in the family, you told me.
That's right. I do have family that went to Clemson, and am now living on the West Coast. So it's been a pleasure to be a part of the infection prevention community. My mentor, Judine Bartley, was actually going to be here but could not make it. So I feel honored to be here in her stead. So I'm going to just zero in on a little tight area of the guidelines that looks at the infection control risk assessment. And this has been a real fascinating journey to see this evolve, and so I'll try to give you a glimpse of what that's been like for those of us that are out there in the weeds actually using this process. So it started with Judine and her colleagues back in 1996, and it was intended to be something that was done organization-wide or to be a multidisciplinary process that allowed the organization flexibility to design their infection prevention intentions around what that organization needed in that community. And it was primarily focused on isolation rooms at that time, earlier on, advisement on how many airborne infection isolation rooms or protective environment rooms you might need. In reality, at this time, I had been in the infection prevention field for about 2 years. I was actually in Florida, working at Florida Hospital from Skip's old stomping grounds. And so those of us who were new to the field or just starting, this was brand new. Certainly there had been things within healthcare, as he had said for years. I mean, we saw a slide yesterday from Florence Nightingale. There had been thought put into infection prevention strategies, but there had never been a systematic process for really looking at patient risk, type of work, and what needs to be designed from involving an infection preventionist. So this was like a baby step towards that. And we began to see tools like this emerge. And this is a kind of the guts of infection control risk assessment matrix. And along with looking at airborne infection isolation rooms or protective environment rooms, there was plenty of literature that showed us that patients sometimes got infections related to the dust and the actual construction activity. So we started to see the use of a tool like this that would break down the different patient risk groups and also the type of work that was going to be performed, and you would come up with basically a class of work which would have different types of strategies for protecting patients or patient care areas such as the pharmacy during the scope of work itself. So it's a sort of a two-pronged approach. And then moving forward to 2001, it continued to expand, and I'm sure those discussions were quite lively in the HGRC. But looking again at disruption of essential services for patients, thinking about patient movement, if you had to do a phased project, for example, and what were the implications of that from an infection prevention standpoint, because there are many implications. Further discussion about ventilation in other special pressure need areas, and starting to look at water, dead legs, the impacts of organisms like Legionella. So again, it just started to kind of grow. And we also saw some other tools emerge. Those of us, again, who are out there actually running programs and working in programs had, for example, this toolkit that came out by the Association for Professionals in Infection Control. And again, this was authored by Judine and some of her colleagues. And basically what it would give you is a way to walk through what were the big rocks in the jar, what were the things that you needed to be looking out for. And we started to have ways to be able to connect with one another to understand, you know, where are you getting involved in this process? Because many infection preventionists were still not getting involved in the process at all, even in the early stages around 2001. Some of them were getting involved in the process, but it might be just right before the start of construction, but certainly not during design, and we still even hear that now. So fast forward again, 2006. Again, we're looking even further into the long-range design planning. So, for example, if you're designing, let's say, an endoscopy center, starting to look at, you know, what are the flow of instruments, what's the business plan for growing the business, how many high-level disinfectors would you need, what is the flow into that room and out, you know, should we be hanging those to effectively dry to line up with the guidelines of how you reprocess those instruments. So trying to really look at designing the spaces to support practice guidelines that were out there. And, excuse me, we started to learn a lot more from one another from having this experience of getting involved in construction projects and seeing, well, what are the mitigation recommendations and measures that people are using, and which ones of them are helpful and which ones of them might be overkill. And so trying to put forward, you know, what methods should actually be best practice, and we saw some of that starting to emerge. And through that we saw a partnership with AHRQ to be able to develop and provide workshops. And the individuals that we see coming to these workshops, and we still teach these across the country several times a year, are generally contractors, some architects, some facility, some project managers, some facility engineers, and infection preventionists. So it's a great course to be able to see the mixture of individuals come in that room, much like what we're doing here now, and hear their different viewpoints on this particular process and the impacts that it has on their scope of work and their viewpoint. And we've seen further expansion of infection preventionists into the project planning, but still I can tell you, when I talk to groups, I was just in San Diego doing a talk last week, and it was pretty much all of the infection preventionists from the San Diego area, and it's still quite variable when they get involved in the planning process. So now we're at 2010, last year. This was really the first cycle when I got more heavily involved in the guidelines. Learned a little bit from Judine in 2006. A lot of work in that cycle on hand hygiene stations themselves, the location of hand dispensers, The language in there is not so prescriptive that you can't ask your providers, such as what I saw here. They've obviously got them outside the room consistently, but there are some organizations that are going to want hand gel dispensers inside the room, and again, based on what your providers tell you and what their practices are, you'll see variations. Same thing with their Sharps boxes. They have them placed consistently here, but you may want in other organizations to put them elsewhere. But what was nice to see is the consistency that we saw here. And we are starting to make inroads in terms of looking at what is going to be helpful for the next cycle of the guidelines, the 2014 guidelines. What do we need from a risk assessment and a design standpoint to help us really point to what are the areas of risk from an infection prevention standpoint? Surfaces, what do we need to know about those? And there's so many things we don't yet know. That's why the research and what the Center for Healthcare Design does is so important, because there's many things we don't know. And when the CEO from Virtua was talking about some of the changes that they had made with this facility and the fact that they had worked on shortening or minimizing the amount of patient movement, and one of the measures he had on his slide was that they were going to look at infection outcomes. And I was thinking to myself, okay, what would be the link between patient movement and infection outcomes? So I'm thinking ventilator-associated pneumonia, head of bed up, secretions. I'm thinking urinary tract infection, not throwing the Foley bag in the bed as you're running down the hall to go to the radiology, decreasing some of those just human factors, operational things that we do by the fact that the patient's not moving enough may in fact decrease their risk for infection. So it'll be interesting to see. But the ability to tease that out and know, is it the design of the space? Is it the surfaces of the space? Is it where things are placed? Or have we changed people's behavior? I don't know that we know that yet. So we have a long way to go to be able to really see what those factors are. I would think that what we're going to see is the infection control risk assessment become a part of this bigger, broader patient safety risk assessment that we're talking about here, because it is right now sort of a process set apart to itself, but if we really think about it holistically, it should be a part of that overall view of the patient. So I would see it continuing to evolve and to come together and merging. And we are planning in the 2014 guidelines to develop a table which hopefully will serve to be able to point infection preventionists and multidisciplinary teams to look at what are the things that are within the guidelines, because there's not a separate section just for infection control risk assessment per se, like a chapter. What within the guidelines should I look at to help me know how to guide my facility if I'm building a certain type of structure or an area within my building? So we're going to develop a table that will basically break it down into categories of different types of design scopes of work and where to find it. And that'll just be our first step towards guiding people more on the design end and not so much on the construction end. We can't put all of the operational rationale into the guidelines, or the appendix would go on forever. So we are going to write a white paper to go along with this. So for example, in intensive care unit areas, if you have a shared bathroom or room for disposal of wastes, and we talked about, does that room need a sink, or is the sink fine if it's in the patient room? And to explain the rationale for why we are going to recommend it to be in the patient room and how that will still serve to protect the staff member and protect the patient will be something like we would put in this white paper to give it a little bit more substance behind what's in the guidelines. So that is yet to come. So again, just in summary, we've seen this process evolve, and it's been amazing to think that it's grown to what it has at this point, just in the short period of time that I've been in this profession. And it has provided, I think, a little bit of a template and a glimpse to spur us on to do a wider sort of patient safety risk assessment. And I hope that it does serve well and continue to evolve so that we can continue to tie it in and merge it with the new processes that we'll be studying here. So that's all I had. Any questions? Okay, Ellen.
Okay, so my name is Ellen Taylor. I'm an architect by training, although more involved on the research side of things right now. Also have an MBA, and you may see some of my bias come across in some of my conversation. So Linda just spoke about the infection control risk assessment and a very specific component of patient safety and looking at patient safety. And in terms of the guidelines, another thing that was introduced in the last set of guidelines was the patient handling movement assessment, a FAMA, as it's called. And Mary Matz, raise your hand if anybody has more specific questions. Please talk to Mary about the FAMA, because she was really an integral part of pulling all of this together. So as Linda said, there's language associated with patient handling in the guidelines themselves, but what I really wanted to talk about is that there is a huge amount of information that is in this white paper associated with FAMA. And that white paper includes a lot of tools, it includes a lot of direction, and similar to FAMA, that's really where we see the patient safety risk assessment headed, where there's certain things that are in the guidelines, but that is supported by a lot of the things that we're hoping that you're going to develop here at this session. So don't feel like everything that you're talking about has to go into the guidelines. We have an opportunity to provide more detail through a white paper. Who has not really used the guidelines before? A few people. Okay, it's okay to say you haven't used them. It's okay. It can be a complicated document if you haven't used it. And what we wanted to do was just run through what the current language is. And Skip mentioned this difference between should and shall. And right now, the patient safety risk assessment is an appendix item, which means you should consider it. You don't have to consider it. You should consider it, which I think is probably not the way most of us are actually thinking about things. But to Linda's point with the ICRA, there's also not a structured way of thinking about patient safety. So in preparing for this event, there's been a number of architects that I've talked to and say, what tools do you use to design for patient safety? What are the considerations that you really think about? What do you present to the client? And it's surprising the number of people that will say, well, we look at it on an individual basis, and oh, well, different teams within our firm look at it different ways, and we sort of start from scratch, and well, we love to have a database, but we just don't have time to actually pull it together. So there's really this need for a little bit more structure and a little bit more consistency. So right now, in terms of the things that you should do, every new or renovated healthcare building should be designed to facilitate safe delivery of care. And it looks at specific definitions associated with hazards and risks. The next component of this appendix item talks about when it should happen. And right now, what it says is during the functional programming phases of a project, the owner provides an assessment of the potential risk to patients inherent in each space and building component that's going to be considered. So right now, we're saying that this happens as part of functional programming. But there's a whole life cycle to the facility design process. And this was given to you as part of your prep material, and people can look at the life cycle in different ways. But if you start looking at the life cycle of a project, starting with your whole strategic plan, what is your business plan? What are your goals and objectives? How are you meeting the needs of the community? How are you providing that care within your facility? Then going into a master planning process and understanding what are those implications in terms of a campus plan or a large complex or a small renovation project. How does this all fit in together? And then how is that supported by your process and operations? So in a lot of cases, if people talk about the life cycle of a project, that process and operational planning tends to happen later in the list. And sometimes people call it transition planning, which is an issue of transition planning. Is that moving the equipment and the furniture and patients, or is it actually transitioning to a new model of care? But what we'd really like to talk about is this whole concept that your operational plan is something that really has to evolve as part of your strategic thinking process, because you're only going to get an effective facility design if people know what they're designing for. Just because you design it in a certain way doesn't mean that people move in and act that way. So this is where we have that fine line that was just talked about, design, operations, but they're linked. They have to be linked, and they will always be linked. So from there, you can really develop an effective functional program. Whereas before, maybe a functional program was just seen as you need X number of square feet, and A needs to be next to B, and B needs to be next to C. Now you can actually start to have a more rich document that actually has more information and more content. And then you move into the more traditional phases of design, schematic design and design development, construction documents, moving into construction, and then commissioning the building, getting through the punch list, and then occupying. So we can talk about all of these phases in a theoretical type of aspect, but the bottom line is that as you move through these processes, the decisions that you make, the changes that you make become more and more expensive. So if you don't start thinking about patient safety until later in your process, chances are it's going to be more expensive to change the documents. Chances are your construction manager is going to tell you, well, that wasn't in the budget. Change order. And that's not a nice thing for organizations to hear. So this patient safety risk assessment, again, trying to add a little bit more structure to the process, get it up earlier into the thought process during functional programming, and hopefully even before then it's on people's radar screen, to try and keep some of these cost issues down. Because a lot of times it doesn't have to cost more. It's just a different way of thinking about it. And Eileen Malone has a great example with some medication safety zones that maybe we can talk about a little bit later in the day as well, that not all changes need to be expensive. So moving on in terms of the language, some of the hazards to be assessed that are identified in this appendix: harmful or stress-inducing agents, noise, vibration, distractions, light, surface characteristics. Again, just suggestions, not that this list is prescriptive or holistic, just some ideas. And what it really starts to tie into is some of the things that we were hearing this morning. What are those latent conditions that really contribute to the active failure? So for any of you that haven't seen this particular diagram, this is the Swiss cheese model of latent conditions, to show that you have all of these different components that can act as defensive barriers between a specific action and a specific result. And what you want to try and do is make sure that you minimize where those holes align, so that you have forcing functions and constraining activities to make sure that you always have another checkpoint before that error is going to start to make its way through the system. And Angeli worked on this and presented it this morning. You can have your different layers associated with the design of a healthcare facility. So you have your latent failures being some of your building design decisions, organizational processes, management decisions, and then you have your slices of cheese, one of which is the physical environment, one of which can be your organizational culture, your clinical guidelines, the teams that you're including, and the tools and technology. Those, depending upon how many safeguards you have set up, can then lead to either error-provoking conditions or active failures or a safe environment. So what we're really here to talk about today is, what is that framework? How do you start thinking about all of these things, and how would that then inform the guidelines? So one of the things that we had done for the 2010 guidelines was to take the show on the road, essentially. The FGI has educational sessions to let people know here are the major changes within the guidelines. And Angeli was instrumental in putting together this design framework of 10 considerations that you might think about in terms of a patient safety risk assessment. And again, this was included in your pre-packet of information if you had a chance to look at it, but really looking at different considerations such as standardization, reducing staff fatigue, enhancing visibility, reducing noise, improving communication, which we heard about again this morning, eliminating the sources of infection through ICRA practices, minimizing environmental hazards, automating where possible, supporting patient and family involvement with care, and the considering of adjacencies within a facility. So again, this isn't saying these are the only things to consider, but these are suggested things that you might want to start to consider, and then start to figure out how do some of these play into specific built environment components. So patient visibility, we saw with the Florence Nightingale picture, patient visibility was great. What happens when you start moving things away? What happens with decentralization? How do you maintain good visibility within a system? There's not necessarily one solution. But if you know what it is you're trying to think about, you can figure out how to solve the problem. So moving on, in this risk assessment language, it should be conducted by an interdisciplinary panel. Again, this ties into everything that Linda was introducing with ICRA, which I was thinking if you just substitute patient safety for every time you said infection control, that's exactly where we need to be going forward with some of this. So you need to have different types of people, safety specialists, medical staff, infection preventionists, architects, engineers. And the report, if that's ultimately what it ends up being, should identify the hazards and specific design features to be included. So the guidelines at this point are not telling you what you have to do. It's merely saying you need to tell us that you've considered it and what your solutions are. And it should be coordinated with the ECRN, as Linda mentioned. If we start to roll all of these different safety considerations together, you know, maybe there's more opportunity to try and make it a holistic document rather than individual siloed components of the guidelines. So again, we can look at these different conditions and look at the framework, but within the guidelines language, there isn't anything to tell people how to do that. So again, we're back at that ad hoc way of looking at things. Each person is going to do it a slightly different way. The results may or may not be the same. There probably still needs to be a certain amount of flexibility, but what we'd like to be able to do is to at least offer the toolbox. So Virtua talked about their toolbox this morning and the different ways that they had of saying, depending upon the type of problem, we're going to use this. If it's a more major issue that we need to deal with, we're going to go all the way up to value stream mapping. There's a whole range of things that you can do within there. And what we'd like to say is, we have a set of tools as well. And depending upon the type of issue that you're dealing with, different types of tools might be effective for different conditions and at different points in the process. So what's next for you here for the next day and a half? As Skip mentioned, the proposal language is due within the next couple of weeks. Don't you worry about that. Others will take care of that for you. The goal here is really to find the whens and the hows. So from this group of brain power, when is the best time to do a patient safety risk assessment? Is it at a particular moment in time? Does it continue through the life cycle of the project, and if so, how? How do you do a patient safety risk assessment? Is it a set of prescriptions, or is it associated with these tools? If it's the tools, which we think it is, when do those tools get used and how? And again, don't worry too much about what detail will go in the guidelines, because we have an opportunity to develop a white paper that will really provide more guidance for people in the end. So this morning, we had a great presentation from what Virtua had done, and we had some great tours to see how that was actually put into action. And as an architect, I can say it's really easy to just start getting drawn into the design of the facility and start asking all of those design questions. And I just like to pull everybody back again and say, try to get away from some of those specifics when you're working in your work groups and really start thinking again back to, how does that tie into patient safety? How does that tie into how I would think about a risk assessment? With all of the questions that you're asking in the end, think back into the process. What are the types of things that you want to do to make sure that those are addressed so that you have the answers in the end and a way of thinking about it in the end? So with that, we'll open it up to questions. If Skip and Linda want to come up, and Angela, you might want to participate in answers as well. Does anybody have any questions? Or, oh yes, I was going to say, if you're all straight on this, I'm going to be amazed.
Talking amongst the organizations that are involved with this, and I guess the HPRT itself, is there any movement to look at getting that out of the appendix, or parts of it out of the appendix? I mean, are we looking at any low-hanging fruit that, no matter what, is researched and we know should be above the line?
I think the goal is, from most people's perspectives, is to try and get it up into the body. I think part of the reason that it wasn't put up in the body, and Skip, you have some wonderful stories about what happened in the last cycle, and I will turn it over so that you can run through some of that. But a lot of it was, there's no meat on the bones. So you're telling people that they have to do a patient safety risk assessment, but you're not really telling them what that means, in which case it kind of flops down to the appendix. So what we want to try and do is provide the detail that justifies it going on.
You have to walk before you run, but the
Yes.
issue is, you know, is there anything right now in the appendix list that this group has looked at and said, you know, we really believe we have research, we have understanding, these things will go up, or we're going to propose they go up? I mean, just to start with.
Yes and no.
Okay.
So we can talk in more detail, but a lot of it has to do with this group here and consensus that's drawn from this event. So Skip, I'm not sure if you want to relay some of your experience.
Can you hear me?
Yeah.
At the 2010 meeting, this language did get proposed that is in the appendix now concerning a patient safety risk assessment. And really, when you're talking about risk assessments, you get a general feedback from a great number of people of, oh no, another assessment. Okay, so people are a little assessment weary, I think, in that sense. I think there are a lot of items in the appendix now, not just the patient safety risk assessment, but there are a number of items in Chapter 1.2 having to do with noise and having to do with, I can't remember all of them, but there's multiple pages of appendix material that you probably need to look at about what do you want to try to move into text. But I will tell you there will be some resistance from the committee members, because some of this has to do with operational issues, not just the physical plant, and how far are the guidelines going to go forward towards making operational requirements for facilities instead of best practices, which is where we are now with it. So that is going to have to be something that will just have to be debated. I wouldn't say don't do it. I mean, you need to get it out there, but just understand that there'll be a lot of debate about it from the floor and from the committees, in my opinion, anyway. And other people in the guidelines here chime in. I mean, you were there, you know, as well as I was. I just had to stand up and try to support the patient safety risk assessment on the last day of the meeting, as I recall, because Ken Dickerman was able to be there. So, you know, you certainly have your opinions.
If you remember, Skip, the biggest problem is that we had a committee of people looking at something and had no consensus. There were, you know, the committee was all over the place as to what did patient safety mean, what should that assessment be, how should that assessment be carried out. And as a result, it ended up becoming just a footnote in the appendix, because we really couldn't come to any real conclusion as to what it should be made up of, and what it should encompass, and how it should be done. And you know, it's sort of, it's not that it wasn't debated, because that committee debated it for 3 years.
And I don't want to
the line until the last.
I'm sorry.
It was above the line for quite a while in the process.
Yes, that's correct, and I don't want to give the opinion, the suggestion that it isn't, that the committee is negative on this. It's not negative. There was a lot of real positive support for it. So I think there were just a lot of definition problems, like Dave was saying. Yeah, Shannon.
I would maybe, to put it in perspective, it's probably following a lot of the same track as the whole private room debate that went on for a couple cycles until you could get enough research, enough information to educate enough people in a consistent way to then roll it in.
So I would just add to that quickly, to whomever asked the question about the Heinz catch-up and does it take 150 years. ICRA's been around for 15 years now, so look at the progress we're making. Only 15 years to look at infection.
Jim.
I just might add, because we have taken this sensitivity about patient safety beyond risk assessment. We are now doing research studies in conjunction with Center for Health Design in 2 specific areas. One is Falls, which is now completed. That is now generating proposals in language changes this cycle. We have another one looking at hand washing and what makes sense and what actually is effective with infection control. That probably will not take place this cycle, because the study right now has been funded but is in the works. It's not complete yet, as the fall study is. And there's some other areas that we're beginning to look at in terms of research-based change modifications in language in the guidelines. So yes, we are looking at patient safety risk assessment, and we're also funding specific studies in various areas of patient safety that make a lot of sense, that hopefully will result in research-based modifications to the guidelines.
Yes, John?
So I'm ignorant in terms of the guideline and the committees, but as I looked ahead to the types of processes or tools that you're looking at, how well represented would you call the human factors group to be a part of? Because more than half of those topics I would, deed over to, a great deal of research and experience in human factors engineering, or the flow. Are they currently represented in your committee meetings and guidelines? It said, architects, engineers, and so forth. I just wondered if that was a subgroup.
I don't know if who's representing that particular subgroup. I do know that in the focus groups that they have experts that they can bring in to give all of that input. Content experts, what do you call them?
The way the structure is, if it's a specialty study, like patient movement was not considered a focus group, it was actually a specialty committee, you can go outside of the AHRQ, which is 140 people, which actually is quite diverse. At one point it was all architects, but it's not anymore. I mean, they have an interior designer, for instance. But yeah, they went out, they have clinicians, they have facilities management, they have people who are actually operators or administrators of hospitals now. The group has increased in terms of its perspective. No patients. I think that's interesting. We don't have any patients on the guideline, as a representative. We all are potential patients, but the issue is no experience, ones who focus on that.
And to your point, that may be a specific language change that we want to incorporate in within the next couple of weeks is propose that. I will say that in helping to put together this group, I was surprised at the number of human factors experts that really get drawn into the process. And when you start looking at the research, the amount of research that's available in that area, and I've been doing this for a little while and hadn't really thought about it specifically that way, but it's an important component.
And I think speaking for the people who are on the guidelines committee, it is growing more and more interdisciplinary. So there are more people, like Mary Max has a human factors background and she's in the guidelines. So there is definitely, I think, a push to have more people with different kinds of background in the committee to provide the feedback. That's a great thing, I think. And if you want to be a part of it, I'm sure we can have you.
I know experts. I'm not one of them. I recently just had attended a workshop with a group of HIV PhDs and their research and their backgrounds in it. So and I was impressed and looked at how it really interlocked with this conversation today too.
And I think that's the reason we have this group here, because as we develop this patient safety risk assessment, there is the language that will go in the guidelines, which might not be a whole lot than what you saw right now, but what is really going to help people is having this white paper, which tells you what to do, when to do, how to do it, and that's where we'll have you all comment upon it and say this is the way to do it, structure it so that it's usable, it's practical, and that it's, supports all the principles that we know of. John Ryland.
I have three things I want to say. One is, I think one of the impediments in the guidelines to having, like risk assessments and things like that be part of the main body is the requirement, and I'm not saying that it should change, but the requirement that the guidelines are minimum standards. I think you should comment on that, because what happens is you get somebody says, well, let's talk about innovations or idea of doing risk assessment, and everyone says, whoa, I don't see any evidence of this. Where's the proof that this really works, right? And what happens is that people, appropriately so, because it's a minimum standard document, does not include it. And so I think that's one of the reasons why it's so difficult to get something like a private patient room. To me, was a huge thing that the guidelines would do that, because it seemed almost a little innovative, in terms of it, even though there was a lot of good data behind it. So that's point number one. And Skip, you want to comment on that?
Yeah, I was just saying, talking about the private rooms, there are still states who do not adopt that part of the guidelines. Understand that that is not a done deal across the United States. Washington State, for instance, no, we're not going to have all private rooms. That's a debate that goes on in the guidelines, but in order to get the guidelines adopted by state authorities to enforce the provisions or the design and construction, it still has to be considered a minimum standard. That's the reason we have the appendix material, and that's the reason it's called a guideline still, is because we have this best practice that is perhaps in the appendix material, and that's how we were utilizing that.
Okay, and the second point is that I'm going to talk a little bit about this in my 10 minutes about the issue of how do you make something safe as distinct from evidence-based, right, which is an important topic about safety is not, evidence-based is necessary but not sufficient to achieve safety in an organization. And that's something I want to talk a little bit more about, but I think it's one of the complexities of trying to create tools and stuff to put it in a set of guidelines, because you can't prove everything that you're thinking about doing, or prove the thought process. You can't say it makes sense I want a blinded study of whether or not I should pull the cord when I'm jumping out of an airplane with a parachute. Well, you would never do that. You just pull the thing because it makes sense to pull it, right? And that's one of the complexities of trying to accomplish what we're doing. But the third thing I wanted to raise, Linda, to you and to other members on the committee, is that one of the important issues around designing for patient safety, the idea of trying to make facilities improve patient safety, is the issue of having the facility support or, in fact, in their own rights, get rid of adverse events. It's one of the biggest issues that has been discussed from the day that this patient safety issue was raised in this country, right? To err as human, is that we're harming people all the time. So the question I have is, why don't we have sections in the guidelines on the adverse events? In other words, it's a big deal that we have so many infections and we're killing all these people and harming all these people in hospitals with infections. Why would we say, under patient safety, we have a discussion in those guidelines on infections, on falls, on medication errors, and the design requirements or ideas that we might have that might mitigate those or minimize those?
So I'll jump in just for a second before Linda and Skip. There actually are people, Eileen Malone in particular, working with a group to start looking at that very type of thing. Again, maybe it's baby steps, maybe medication errors comes in next cycle, maybe falls comes in next cycle, we have infection control, maybe there's other components that start to come in based on what are those adverse events that you're trying to address.
But why wouldn't we have separate, why wouldn't we just have the guidelines have a separate section on infections where we don't have to look at
Skip brought up a point when we were preparing for this. Why don't we have a chapter on patient safety? Why is it skipping throughout the document? Why do we need a user-friendly table? Why wouldn't it just all be in one place?
Yeah. And I think the name of the document is the Guidelines for the Design and Construction of Healthcare Facilities. And that gets to be the issue. Where do you draw the line between design and construction and operation? And what you're talking about,
let me just say,
you're trying to create design to support operations, but then you fall over into operations oftentimes, and perhaps there does need to be another chapter or part in the guidelines that talks primarily about operational issues in relevance in regard to design. And maybe that's a separate section that we'll have to develop. I don't know the answer to that. I do know it's a rub, though.